I'm Dr. James DiNicolantonio, lead author of StatinWars heavyweight match, Atorvastatin versus Rosuvastatin on atherosclerosis, heart failure, and chronic kidney disease. I'd first like to thank my co-authors, Carl Levy, James O'Keefe, and Victor Cerebruani for their excellent contributions to this publication. There has been a long-standing notion that a class effect exists between medications within the same class, but when you look at the evidence, such as hydrochlorothiazide versus chlorthalidone or Actos versus Avandia, differences between classes can lead to clinically significant differences on outcomes. So what our goal was is to extensively review the literature comparing the two most potent statins, Atorvastatin versus Rosuvastatin. And these statins, they couldn't differ more pharmacokinetically, as they are both on the opposite ends of the spectrum. You have Atorvastatin, or Lipitor, which is lipophilic, mainly metabolized by the liver, CYP3A4, and you have Rosuvastatin, or Crestor, which is mainly eliminated via the kidneys. It's very hydrophilic and is not CYP3A4 metabolized. And what we did is when you look at the evidence on atherosclerosis, the trial that comes to mind is Statin. Now there are several other direct comparison trials of Atorvastatin versus Rosuvastatin on atherosclerosis, and what we find on the primary endpoint in Statin was there was no significant reduction in percent atheroma volume, despite the fact that Rosuvastatin caused a highly significant reduction in LDL cholesterol compared to Atorvastatin. Now, secondary endpoints were significantly reduced with Rosuvastatin as far as total plaque volume, but that can partly, if not mostly, be explained by the reductions in LDL cholesterol, an unfair advantage to Rosuvastatin. So we deemed a tie on atherosclerosis trials. Now, when we look at patients with heart failure, there is certainly disparate results between Atorvastatin and Rosuvastatin. A nice trial that sets the tone on this is in dilated cardiomyopathy patients. 4 endpoints were significantly reduced with Atorvastatin, not just significantly reduced, but as well comparing to Rosuvastatin. And those endpoints were oxidized LDL, cardiac sympathetic nerve activity, left ventricular ejection fraction, and NT-pro brain natriuretic peptide, or NT-proBNP. Now, all 4 of those endpoints are independent prognostic indicators in patients with heart failure. And we saw significant reductions with Atorvastatin on all 4 of those endpoints, with no significant benefit with Rosuvastatin. And it was thought and proposed by the authors that because Atorvastatin is lipophilic and can penetrate into cardiomyocytes, it can reduce oxidative stress in the heart, such as why perhaps oxidized LDL was significantly reduced with Atorvastatin, whereas this was not seen with Rosuvastatin. And it was this reduction in oxidized stress that the authors also proposed a potential benefit on cardiac sympathetic nerve activity. Now, cardiac sympathetic nerve activity is important because initially in heart failure patients, there is an increase in sympathetic tone. And this is perhaps due to a reduction in cardiac output. But eventually in chronic congestive heart failure, you have a depletion of the sympathetic reserve. And so what you have is, we have a marker for norepinephrine that uses the same receptors in the heart to be taken up, and that's called meta-iodo-benzylguanidine, MIBG. Now, we use 2 measurements, the uptake of MIBG in the heart versus the mediastinum, and that is reduced in heart failure. This was significantly improved with Atorvastatin. And then washout rate of MIBG is increased in heart failure, and the washout rate was significantly improved with Atorvastatin. So we clearly see that these 2 potent statins have different effects, and we can measure them with those 4 independent prognostic indicators. Now, supporting this trial is a meta-analysis, 17 randomized controlled trials of approximately 1,500 patients, equally shared by Atorvastatin and Rosuvastatin. And what we saw was the same thing, a significant improvement in left ventricular ejection fraction, greater than 2.5%, and significant improvements in brain natriuretic peptide. This was not seen with Rosuvastatin. So clearly something is going on, something mechanistically, that is allowing Atorvastatin to show these benefits, whereas Rosuvastatin does not. And this is also echoed by another meta-analysis of 7 randomized controlled trials in greater than 500 heart failure patients, And atorvastatin showed a greater than 60% reduction in all-cause mortality, a greater than 70% reduction in cardiovascular mortality, and a greater than 75% reduction in sudden cardiac death. We also have the TNT trial, where 80 milligrams of atorvastatin was compared to 10 milligrams of atorvastatin, and the 80 milligrams caused a 26% reduction in heart failure hospitalizations compared to the 10, and in patients with a prior history of heart failure, there was a 41% reduction in heart failure hospitalization. So what we get from this trial is there might be dose-dependent benefits with atorvastatin. Now, the evidence for rosuvastatin in heart failure patients is quite opposite. We had two large randomized controlled trials, Corona and Gizzy heart failure. There were no benefits with rosuvastatin. And in the Universe trial, there were actually increases in markers of cardiac fibrosis. So collagen turnover, these N-terminal pro-collagen peptides were significantly increased with rosuvastatin. So that questions, does rosuvastatin potentially increase cardiac fibrosis? In the chronic kidney disease realm, atorvastatin has a long history of being renal protective. We have the Greece trial, which showed a 5% reduction in creatinine clearance with patients that were not treated with statins. We had a increase of about 5% in creatinine clearance with use of other statins, such as pravastatin, simvastatin, lovastatin, but we have a much bigger increase in creatinine clearance, 12% with atorvastatin. There were also significant reductions on stroke, all-cause mortality, coronary heart disease with atorvastatin compared to those other statins. And we also saw a dose-dependent effect again, where higher dose of atorvastatin was more renoprotective than lower doses of atorvastatin. Another large trial, a 4-year trial called Alliance, indicated the renoprotective effects of atorvastatin. There was a significant increase in creatinine clearance of about 0.8%, but this was at over 4 years of follow-up. Whereas there was a significant reduction in patients that did not receive atorvastatin of about 1.5%. Now, a meta-analysis echoes these benefits in these large trials of 27 studies of 40,000 patients, indicating that statins, they reduced the decline in estimated GFR by about 1.22%. But when meta-regression was done, almost all that benefit was due to atorvastatin. There was a 2.5 ml per minute greater, slower reduction in GFR with atorvastatin versus other statins. So clearly atorvastatin is unique on renal protection. Now, when we look at TNT again, the 80 milligrams of atorvastatin versus the 10 was significantly more renal protective. And in patients with previous history of chronic kidney disease, we saw a 32% reduction in cardiovascular events with the 80 versus the 10, and about a 21% reduction with 80 versus 10 in patients without chronic kidney disease. So we see dose-dependent effects as far as reduction in cardiovascular events with atorvastatin and improvements in renal function. Now, the real nail in the coffin with the renal protection of atorvastatin versus rosuvastatin was two large randomized controlled direct comparison trials, Planet 1 and Planet 2. Now, Planet 1 was in patients with type 1 and type 2 diabetes, and Planet 2 was in patients without diabetes. And these patients had a high baseline urinary protein to creatinine ratio of anywhere from 500 to 5,000 milligrams per gram of creatinine. And what we saw was a significant reduction in proteinuria with atorvastatin, approximately 15 to 20%. We saw only a 1 to 2 ml per minute loss in estimated GFR over 52 weeks, whereas on patients on rosuvastatin, 10 milligrams, patients saw a 4 ml per minute loss in estimated GFR. In patients receiving 40 milligrams of rosuvastatin, they had an estimated 8 milliliter per minute reduction in estimated GFR. So clearly, that could be clinically significant. If you have someone that has chronic kidney disease 3 or 4, they could certainly be pushed to dialysis much faster if they're given rosuvastatin versus atorvastatin. Thank you.